Good morning, everyone. My name is Diane Cohen, and on behalf of Work Comp in Motion, we'd like to thank you for joining us for today's presentation and discussion. Before I get started, there's a few housekeeping items I'd like to cover. For example, the presentation from today is attached to your control console. Please make sure that you go to the control console and download that for your records. Secondly, if you need CEU credits, you will receive them tomorrow. It takes 24 hours, so sometime after noon tomorrow, you'll get an email from customer care at GoToWebinar. It'll say, your certificate is here. There's a little blue button. Please make sure you click onto that, and then you will be able to download your certificate. Lastly, if you have any questions today for Doctor, please use the question or chat box, and I will be happy to ask him those questions at the end of the presentation if there's time. I'd like to thank our sponsors for today's event, the Endless Summer event. We have a 3-part series, and today is the last part of the series. So we'd like to thank work partners, MacroPro, Siegel Marino and Stetler, ProCare, Gen X, Corbell, NewQuest, iRatings, Learning Services, Ember, Optum, Dental Works, and California Orthopedics. So today our presentation is on new advancements in shoulder surgeries. We have Dr. Cutuk from California Orthopedic Surgery speaking with us today. They're one of our sponsors. Doctor, thank you so much for coming to speak with us today, and it's been delightful to get to know you, and I know our guests will really appreciate the information that you have. So the presentation's all yours.
Thank you very much for having me. I look forward to answering any of your questions. And I just wanted to take this opportunity once again. You guys are wonderful, and thank you for the opportunity for us to come in and present. And I hope that this is somewhat educational and you guys can kind of learn a little bit about shoulder surgery, what we do, and also dispel some of the dogmas that are out there regarding shoulder surgery. So hopefully you walk away with some valuable information for you and your clients and family and everybody. So we're going to get started here. And, again, my name is Adnan Cutuk. I'm a sports medicine shoulder surgeon in the California Orthopedic Institute. I do mostly shoulder and knee surgery, and probably about half and half of my time is split between those two joints. And I'm going to kind of dive right in. So as you guys know, shoulder pain is very common. I'm going to go over briefly shoulder anatomy review, and then we're going to discuss some of these common shoulder problems that you probably have heard of. You might have had friends or family or clients that have had this, and then we'll touch upon some of them, or at least most of them, in some way, and hopefully provide some additional understanding about all of these conditions listed here: rotator cuff, impingement, biceps tendonitis, shoulder instability, and labral tears and nerve impingement, etc. So shoulder joint, I always like to think of it in kind of analogies. I think of it as basically a golf ball sitting on a tee. And so it's a big ball that's balanced on a tiny little socket. The socket is actually pear-shaped, which you can see up here. It kind of looks oblong on toward the top. And the labrum, which is the tissue that goes around the edges, basically you can think of it as it takes this little flat dish and turns it into a deep dish. That deep dish allows the ball to balance itself and provides stability. In addition, the shoulder has outside structures, which is multiple ligaments here. The most important one is that little guy down here, inferior glenohumeral ligament. But there's also other ligaments that you may hear me talk about that have problems or pathologies when they're torn, such as corticoclavicular ligament, which is the ligament between this little prominence of the scapula called coracoid and the clavicle, and those are the ligaments that are often torn when people separate their shoulder. Long head of the biceps is one of the two biceps tendons. Its function is not totally clear anatomically, but it's there, and it's often the cause of pathology. On the top of that layer, there's another layer of 4 muscles. We call them rotator cuff. They're called rotator cuff because they're kind of like the cuff. They go all the way around the head, and you can see here they kind of wrap all the way around the head. And they're called rotator because they're responsible for probably 80 to 90% of stuff we do below our nose level. So any kind of shoulder rotation with our arms around below the nose level, these 4 muscles are the ones that are doing it. The most common injury of those 4 rotator cuff muscles is the one on the top, which is depicted here, torn. And basically, we see it when people have, you know, they can be traumatic or it could be attritional. As we age, all of our tendons, for whatever reason, specifically these 4 rotator cuff tendons, age and they're prone to getting little tears. Those tears we can separate into chronic or attritional tears, which means people might have a tear and not even know that they have it, versus traumatic. Traumatic is, you know, like depicted here. You fall onto your arm or you try to lift something heavy. Very common story is I was lifting a luggage into the bin, overhead bin, and they experience pain. And they can get these tears, and the tears can be partial versus complete. And what we mean by that is complete involves the entire thickness of the tendon, and partial is only partially torn. These are the most common symptoms, and almost always it's a night pain. This is what drives people to clinic, is if we can't sleep and get a good night rest, we're not very nice people. And eventually we end up saying, okay, I got to go in and get this checked out. So almost everyone has the night pain. Limitation with overhead activity. So if we were trying to reach top cupboards or lift something overhead, lifting the arm weakness. So, you know, trying to lift our grandson or grandchild or a child, or just the, you know, taking the trash out, we can experience it. Putting on a seatbelt is a good common one. People say they can't reach to pull their seatbelt across when they're in the car. And then of course there's you know, washing the hair, reaching our head to wash our hair or do a makeup. For biceps tendon, you know, we often can see pathology with biceps tendon, but more commonly, I always like to think of a biceps tendon as the byproduct or kind of a caught in the crossfire of other problems in the shoulder. It's not very common that the shoulder biceps tendon tears by itself without having associated problems in the shoulder. So when we see biceps flared up, I always look for other things that could be wrong with that shoulder, and most of the time that's the case. Basically, by the time the shoulder starts telling us it hurts, we know that there's some other things going on probably in the shoulder. The way we diagnose it is by basically looking for you know, tenderness in the groove, which would be the pain in the front of the shoulder. This active compression test, which is illustrated here, and then you know, pain with the front resisted joint position, kind of like this middle photo down here. And just with clinical examination, we can clue in and recognize something's going on with the biceps. Usually it's a chronic inflammation. Sometimes it can be a partial tear. Impingement, this is a real thing, but often this is what we see a lot of doctors, even some surgeons, use as a kind of a catch-all basket for, you know, when they can't figure out what's going on with the shoulder, they always assign it an impingement, and they say, oh, it must be impingement that's going on. And although, again, I think this is more of a product of underlying rotator cuff issues or underlying shoulder problems that are then manifesting themselves as impingement. So what about rotator cuff? Going back to it, these kind of 3 things often will go together. There will be a rotator cuff tear, there will be impingement, and then there will be a biceps issues. Because we are very simple-minded surgeons, we're not very fancy like neurosurgeons, we classify these things very simple way. We just say, basically call them small, medium, large, and massive. And what that really means, and it is a real classification, is less than 1 centimeter tear. And when we talk about size tear, we talk about how far this little tendon here has retracted and pulled back, like kind of like a curtain. How far is it like retracted away from where it needs to go, which is over here on the tip of this humeral head. So small, that would be only a centimeter retraction. Medium would be 1 to 3, a large would be 3 to 5, and the massive is usually, by definition, more than 1 tendon is torn. In order for example, supraspinatus to pull back that far, infraspinatus has to be torn as well. So how do we repair it? You might actually still know or see people that are still doing these mini open. I will make a case that most of us I've been in practice for 12 years. Most of the people in the last 12 years have switched to doing it arthroscopically. Why do we do it arthroscopically? I think my bias is that it's better. We get a better, we're reducing morbidity related to surgery. So we're not making any big incisions. There are 4 little holes that we just do. We lower surgical risk because we're not doing a big dissection. We can perform soft tissue releases more adequately. We can reach parts of the shoulder with a camera and instrumentation that we cannot do through a small little incision. And then also we can address other problems. You know, there's people that have a labral tear or impingement, and those are harder to address when you're just doing a mini open incision. Mini open, this is what it looks like. You make a little incision and you can kind of see a little tear, and then you're trying to repair everything through a tiny little skin incision. Arthroscopically, we just make little poke holes. We introduce this what we call arthroscope or a scope into the shoulder. Shoulder's filled up with fluid, and then basically we can kind of go anywhere we want in that shoulder and address all the pathology that's associated with it. But just remember, just like this cartoon says, the associated pathology doesn't mean necessarily the cause of the problems. So people can have multiple issues, but doesn't mean that one is causing the other one. It just they tend to go hand in hand together. So why is arthroscopic rotator cuff repair important? Well, not just why it's important. Why it's important to be done by, I think, people that are very proficient in doing it. I think it's because there's a lot of subtle things that people that don't do a lot of these annually, meaning surgeons that don't have a lot of experience with these, can often miss some of the subtle things that are very important in healing and ultimately in the outcomes. So if you look at it here, not all large tears of these tendons are the same. We have to recognize these different patterns because how we repair it, it depends on how it heals. So if you're repairing a reverse L-type tear and pretend, or we think that it's a U shape, we will not repair it anatomically, which means parts of the muscle will be under bigger tension than other parts, and that can affect healing rates. That can affect, ultimately the strength the patient has after healing, and those are very important to recognize. And so it comes with experience in doing a lot of these. How do we repair it? We usually basically have these little, what we call anchors, which is tiny little screws. They can be made out of metal or biocomposite. I think a lot of us, including myself, use these biocomposite anchors. What they are is they're made out of the same material that's mostly present in your bone, calcium, phosphate, and sulfate, and they eventually turn into bone. So, a few years after repair, you can't even find these anchors. They basically just become part of your bone. The metal ones stay in forever, and you can see them on the X-ray, but I think a lot of the people have switched to these biocomposite ones. We usually will address the impingement at the same time. Before we, it's very rare that we address impingement in surgery by itself, although people that are refractory to non-operative management will often require surgery to clean out that bursal inflammation and smooth out this undersurface of the acromion. But you can kind of think of it as this diagram or this picture shows. You have a little bursal tissue here, and it can get inflamed and hypertrophies as it gets chronically inflamed, and then creates this little impingement with motion of the shoulder. And usually we can address it by smoothing out the undersurface of this acromion, removing a tiny little part of it, and also cleaning out this bursa completely. So the surgery for impingement is very straightforward, and patients often require no sling. They have no restrictions. They can start physical therapy immediately, and their recovery is fairly quick. Here's an example of a patient of mine that I treated a few years back, and basically this was when I was still living in Midwest, and the person fell on ice, slipped, and you can see these are, I know some of these look like very weird looking demonstrations from inside of the shoulder, but I'm going to try to explain it to you. All the red is inflammation that's a result of that chronic or acute tear. This is on this middle bottom picture is where I'm actually grabbing this entire sheet, these actually 2 tendons that are torn, both infraspinatus and supraspinatus, and pulling them back, and this is where they should be attaching. This is the bone where they're ripped from, here and here. And you can see that what we do then is we smooth out the undersurface of the acromion. We can see that visualization is really nice. And then we can do a nice little repair of that tendon back to its bone, hold it there with these little sutures and anchors. And then this is the patient 6 months post-op. You can kind of see that it was his left arm because he's still working on that last few degrees of forward flexion, but he's an avid tennis player. He also happens to be my colleague who works in a neonatal intensive care unit at the Children's Hospital, and he was, really concerned that he couldn't, he wasn't able to lift his arm, and he wanted to go back to work, and involves lifting a lot of little preemie babies to examine them. So he wanted to have a functional shoulder with good strength. So he had a good outcome, and he's pain-free. He returned back to playing tennis. So biceps tendonitis, as I mentioned earlier, it's very rare that you see a biceps in flare. And the biceps, by definition, the muscle has two tendons. The main one attaches on this little bone called coracoid. That's the power generator behind biceps motion. But this little guy, we really are not 100% sure. We're still debating what its function is, other than it can get inflamed in this little tunnel or inside of the shoulder and cause a lot of pain to people. Short of addressing it with surgery, we can, inject it. We can do a lot of the physical therapy modalities that can be helpful. But ultimately, we can either cut it out of the joint, let it release its tension, or cut it, release it, and then reattach it down here on the bone. So, but what happens if we do this and we do not have satisfactory results? This is, I think, where expertise comes in, of having experience of seeing a lot of these and doing a lot of these, is to pick up on these few cases that didn't go so well, that there is an issue, and then recognizing what the underlying issue might be and then addressing it. So just like this graph, I think, what if we fail? Well, we all get to laugh at you if we fail. So this is a patient that was referred to me who had a left arm weakness. He had arthroscopic rotator cuff repair 6 months prior to seeing me by another surgeon who was a good surgeon who in the community, but he continued to have weakness in lifting his arm. And, he did the same usual thing. He had 5 weeks in a sling. Then he went to therapy. He was very diligent about going to therapy. He continued to have this dull ache, pain, and his main issue was he couldn't lift his arm up. His kind of exam looked very similar to this, where he just could not lift his shoulder above his head. We could get his shoulder up there, so I could lift it up above his head so he wasn't stiff, but he just didn't have power to get it there himself. The original surgeon repeated the MRI, looked at it, saw, and you can see here the tendon. You can see that here the tendon is healed. The anchors are down here in the bone, but the tendon, we can follow it all the way to its insertion point. And we can see supraspinatus and infraspinatus muscles. So the surgeon really ran out of options, said, I don't know why you can't lift your arm up. I see your tendon is healed, so keep doing therapy. So as a part of his frustration was he came for a second opinion. And one thing that stood out to me, oops. One second. Hello? Can you guys still see me?
Yes, doctor, we can see you.
For some reason, it won't let me advance my slides. Oh, let me see. There you go. So one thing that I immediately stood out to me, which, it's very subtle, and I'm going to point it out to you. And once I point it out, you guys will notice it too. There's a difference in shade of gray here between this muscle and this muscle. This muscle is darker gray on the MRI, and this one looks lighter on the MRI. And what that often means, you can even see it here now, again, lighter muscle, darker muscle. And you can see the tendon is fully healed. It's all the way attached here. And what that tells me often is one of the first signs of MRI changes with denervation of the muscle, which means muscle has lost its nerve connection to the central nervous system, is this change in the shade of muscle tissue on the MRI. So immediately I started thinking there's got to be some kind of a denervation reason. And you can see it here again on a different image. This is a cross section. This muscle is lighter than this muscle. And sure enough, there is a thing called, I sent it for an EMG test because I was thinking of this problem. There's a little suprascapular nerve, which is the nerve that travels and innervates this muscle. And it goes through tiny little tunnel here. And often when we repair rotator cuff tendons, it can get kinked. And what it does is it cuts off nerve connection to these two muscles. So it basically, think of it as like a carpal tunnel problem in your shoulder. The EMG did show that there was a nerve that was actually being blocked at this level and not at his neck, which often, people can have a neck problem and have their nerves pinched in their neck. And, I always, when I teach residents, say, there's never it's very few things that are very brand new. So sure enough, this is not something that's like very new. This was described back in 1936, this condition. Basically, traction from a massive retracted rotator cuff can kink this nerve. So if the cuff tears and it retracts back, it can cause the nerve to stop conducting. You can get a big cyst. About a third of all professional volleyball players have developed these cysts. And that's because they get these little tears of labrum, and those cysts then can cause compression of this nerve. And as a result, you can get atrophy, chronic pain, dull pain. This nerve doesn't have a sensory branch, so there's no sensory deficit that we can test for. But it's very easily treated. You can actually arthroscopically go in, and all you have to do is release this little ligament and allow that nerve to breathe. So here it is, this surgery. These are pictures from this guy's surgery. Here's the arteries. We're staying away from it. Actually, you can see this little probe is pushing the artery out of my way. This is the little ligament, and the nerve is yellow down below in the little tissue of fat. And then we just come in with the little arthroscopically with the little scissors and release that nerve. Release that little ligament, and the nerve is now free. And the results are dramatic. This gentleman was actually a contractor for U.S. government in Afghanistan. And about 6 weeks afterwards, he said, I am doing so much better. I'm going back to my assignment with my company out in Afghanistan. And I promised, I made him basically at 3 months send me a picture that he's still attending physical therapy and that he didn't end up getting, slacking off. So I said, take a photo of you with your arm above your head. And there he is, proving it to me that he finished his therapy and did everything the right way. So he recovered. So you can see that if you don't, even some shoulder surgeons and people that do rotator cuff often don't think of these lesser conditions that can be critical. And so he had a great repair. He just needed that little release to help him get back to 100%. Shoulder dislocations, we've all heard people, usually people dislocate. When the younger people dislocate, they tear these little labrums along with the capsule. But we now recognize that people over 40, when they dislocate their shoulder as a result of fall or trauma, will tear their rotator cuff. So we almost always, after dislocation, order an MRI. Shoulder, and then as a result, we can repair this. In the younger people, instability becomes an issue, meaning repetitive dislocations. So we'll repair this capsule and a labrum. We call that a Bankart repair. But anybody over 40 or 50, when we recognize a rotator cuff tear, we also want to repair those, just like that colleague of mine who had a traumatic rotator cuff tear when he fell. We want to fix those because they do better when fixed immediately rather than when they're just ignored and fixed down the road. And then finally, shoulder arthritis. This is one of those things that, even to this day, I have patients come in and say, I had shoulder arthritis, but I was told by primary care doctor or by somebody that never have shoulder replacement because I will never be able to do X, Y, or Z. And it's not really true. You can do shoulder replacement surgery and continue to live your life with very, very little restrictions. So what do? We basically, shoulder arthritis develops, and then we lose motion, stability, strength, and smoothness, and the shoulder replacement will give you all four of those back. How do we recognize this? Is very easy. This is one of those diagnoses that if you get a single x-ray, you can tell. On the left here, you can see what the normal shoulder joint looks like. You can see there's plenty of joint space here, 3 to 4 millimeters of cartilage that we don't see on the x-ray. It's there. And then you come over here and there's just absolutely no space. The head is already flattened out. There's big bone spurs that develop as a result. And so this shoulder is pretty bad shape. Again, think of it, another view, we call it axillary view. Think of the shoulder like that golf ball sitting on that little T on the pedestal. And you can see here, the T is all grinded down. The ball is no longer round, it's flattened out. So we got to restore all of that back to normal. Usually I always teach residents, when you go in, you can see this classic pattern where centrally the cartilage is all gone and there's a little ring of cartilage that's left. And it kind of reminds us of these guys. We are in San Diego, in the land of Padres. So the figurines of Padres are everywhere, but this is the haircut, the prior tuck from the, that's how you can kind of think of it. That's what the humeral head wears out usually in a similar pattern. We can get CT scans, and often they're useful to kind of tell us how bad the socket is, because not all sockets can be replaced. When you get to these type C sockets, a lot of times it's very hard to replace or resurface them with the little button. So usually those people are kind of left to having a half of a shoulder replacement. They'll still get about 80 to 85% pain relief, but it's not going to be 100% because the socket cannot be resurfaced. Again, everybody says the shoulder thing is the new thing. Well, I'm going to show you a little history. It was the first joint to be replaced. So it was before the knee, before the hip. First hip was done solid 26 years later. First shoulder was replaced in 1893 by this gentleman, E.J. Penn. He was basically had a patient who was a 37-year-old baker who had a disseminated TB, tuberculosis, that was basically in his shoulder and destroys the shoulder. And every time I tell the story, I'm grateful that I don't live back in those days, because I did not want my baker to have active TB as he's baking the breads for sale. But that was what was happening back then. This is the actual implant. It's in a museum in France. They designed it, him and his friend who was a dentist. It did not last very long, primarily because the patient didn't last very long. He ended up dying from tuberculosis, but they preserved his shoulder for the teaching. Now we are on the 4th or 5th generation of these implants. So we can do a very good job in restoring our, both motion, stability, strength, and smoothness. But the key is to restore everything to patient's native anatomy. One size fits all does not work very well, and you have to be in tune with this with anatomy of every individual patient, because there's a lot of variability in the shoulder anatomy. And for best outcomes, you want to have that anatomy restored back to what the patient had before arthritis, and not what everybody should have based on the implants or certain diagrams. So we can do, as I mentioned earlier, half of a shoulder replacement. We often do it for these bad breaks of the shoulder, where we're only restoring the socket part, the ball part, and then the socket is left alone, but we can also do everything. In order to do this, basically, for hemiarthroplasty, we call it, what are the indications? Well, we can be really bad fracture. It can be that the cartilage does not have sufficient bone left. It could be that there's a cuff arthropathy or patients that have very high demand, so they're young and we're worried that they're going to loosen their socket. We template it, and then on the right you can see we try to match that template to what our goal is. Postoperative recovery is fairly quick, 1 to 2 days, sling for 4 to 6 weeks to protect the muscle that we take off from the front. And then more recently, in the last 10 years, there's a comeback of a reverse shoulder. This is a good solution for patients that don't have a rotator cuff. And what it does is allows this deltoid muscle on the outside to basically become a primary motor force for their shoulder. And it's called a reverse because we're flipping the ball then is going to turn into a socket here, and then the socket becomes a ball. And that's why I call it a reverse shoulder arthroplasty. You can see it here. It allows, basically by changing the fulcrum pool of this muscle, allows it to function through the full range of motion and gives the patient a strength. There's implants that can go back and forth interchangeably now, so it makes it a lot easier if you have to transition from one implant to another. For example, patient that has had a total shoulder can now be converted to a reverse with keeping their own stem, which makes it a less invasive revision surgery. Typical recovery, I have 1 to 2 days. I'm pretty much now down to outpatient or one-night stay. Next morning after breakfast, they go home. We don't keep the patients in anymore. Most of them, with the current pain management, with the nerve blocks that we can do, they can go home the same day. These are a couple of my patients. Total shoulder. We can't even tell. I couldn't tell which shoulder it is.
To the side.
Yeah. And then this is a patient with the reverse. She had this one done first. 6 months later, we did this one.
And then it could come back down.
Again, she's doing great. You can see what a dramatic ability to raise overhead versus what she had before on both shoulders. So outcomes can be great, and with both surgeries, and we just have to kind of recognize it. There's very little restrictions. I let people play tennis and golf if they want to. Very few people can actually do stuff to their shoulders after replacement that I would be worried about. So that's it for me. I will be happy to answer any of your questions, and I hope you guys have a little bit now more understanding of what we do for the shoulder these days.
Well, thank you so much, Doctor, for your presentation. It was very thorough, and I have to say, I truly appreciated your visual analogies. It really made it much easier to understand what was going on. I do have a question regarding COVID-19. Is there a big change in the way that surgeries are being handled, wait times, that type of thing? What is being affected by COVID-19 in surgeries?
So currently, right now, as long as the hospitals are not on that, as long as we're not overwhelming the hospitals, which we were able to in California at least keep up with the number of patients that we've hospitalized, we're not overwhelming the ICUs. We are allowed to continue elective surgeries. One thing that we do is everybody gets a COVID test going into the surgery. So 2 days prior, all of the patients are asked to quarantine as much as possible leading up to the surgery, and then they are given a COVID test. So that we know that they're negative. That's primarily to protect the anesthesiologists and the staff in the room. And it has made us kind of make some changes in a hospital setting where we can send some of these patients home right away. So since we've reopened for elective surgeries in most of the facilities, I'd say almost all, I'd say 95% of my knee replacement patients and shoulder replacement patients have gone home the same evening. So they come in, they have surgery, they get a couple of sessions of physical therapy, and by that evening, by 5 p.m., they're discharged home. So that's kind of been on the horizon. It was coming. I think most of the providers will be authorizing, starting in November, only outpatient knee replacement and shoulder replacement surgeries, but we will have to have a medical reason for them to admit the patients for these procedures. So I think it's kind of accelerated the process, but I think we were going in that direction anyways.
I have a question here from someone, and I'm going to read it as it is. It says, frozen shoulder as a result of failing to participate in HEP.
Yeah.
This seems to be quite a problem in the workers' comp claims. What can we do to correct this issue?
Yeah, so there's various degrees of how aggressive surgeons are and how much time we spend explaining to the patient what they can and cannot do. For example, my typical protocol is 4 weeks in a sling, but I do not tell patients to stay in the sling religiously 100% of the time. What I do tell them is that they immediately begin pendulum exercises. They immediately need to start bending their elbow back and forth. And then I do want them to raise their shoulder with the help of the other shoulder to about the nose level. they can do that safely without affecting rotator cuff repair. So if I feel like I feel like and I strive that all of my repairs are secure enough biomechanically that they can do that, so that at 4 or 5 weeks after we're done with the sling and we start active full-time physical therapy, most of them have already 90 degrees of forward flexion. And then I spend time explaining to them the importance of then utilizing the following 6 weeks and focus only on regaining range of motion. So I don't care about anything else. First 6 weeks is sling with a very limited use, but then the second 6 weeks is I don't care about anything else but restoring their motion. So I'm very aggressive at that point and really pushing them. And if I notice that they're lagging behind, then I spend a little more time with that patient explaining it to them why it's important. That being said, some people still end up with a little bit stiff. I'd say off the top of my head, in the last 5 years, I've had one patient that I had to manipulate under anesthesia, and I do 2 to 3 of these a week. So it's I think a lot of it is education. A lot of it is doing adequate, strong repairs that they can withstand some of that motion. And then providing the patients with proper guidance to like what they can and cannot do, so that we don't want them strapped in like this with arm to their body 24/7. I actually tell most patients they can start typing and writing right away, as long as their elbow doesn't leave their side. They can start doing stuff down here right away with it, and that seemed to work fine.
All right, we have another question for you. So the question is, what type of exercises should be done to protect the shoulder and labrum from tears?
Great, that's a great question. I would say for healthy shoulders, if you've had any shoulder problems and you've had utilized a physical therapy, I really like all the patients to learn a rubber bands program. It's very simple. There's a variable rubber bands that you can get from physical therapists and even some exercise stores, and they have variable tension or tensile strength based on the color. So lighter colors tend to be a little more stretchy. Darker colors tend to have more resistance. And just the 5 or 6 of these rotator cuff directed exercises with rubber bands is a really good way to prevent the tears and keep those rotator cuff muscles in shape and keeping the guys away like me away from you.
Another question we have is, are there cases where shoulder injuries have gone on too long to obtain a total shoulder replacement?
The only thing that I could think of is there's cases where the glenoid is so severely worn that I can't resurface the glenoid, but I can almost always replace, I can always replace the head. So I can always do a hemiarthroplasty. The socket might have gotten grinded down to really no bone stock left, but even those patients will have 85% pain relief. Now, patients that don't have rotator cuff in addition to that, then it's a little challenging, because we still need a good bone to put that little ball for what we call reverse shoulder, which I talked about at the very end. And if that's worn, then yeah, we can provide them with a shoulder replacement or half of a shoulder replacement, which will give them pain relief, but not necessarily improve their function, meaning how strong their shoulder is or how far they can reach above their head.
Got it. There are a few more questions that we have here. Someone had asked about talking about falling as part of the home exercises program, which can cause the frozen shoulder. Can you discuss that a little bit?
What specifically about falling or frozen shoulder?
They're just talking about home exercise programs that can cause this issue.
So there's not a lot of home exercise programs that can cause frozen shoulder. Frozen shoulder tends to be one of those things that kind of, again, a catch-all basket. Whenever there's any kind of problem with the shoulder, I've seen primary care doctors or other surgeons say, oh, it's a frozen shoulder. The definition of frozen shoulder, there is a condition called adhesive capsulitis. And that definition of frozen shoulder is passive and active range of motion is identical or within 10 degrees of each other. So if the patient lifts their shoulder and it only goes to about that far, and then I grab their shoulder and I can only lift it to about that far. That is by definition frozen shoulder. If the patient can lift their shoulder, but then I can grab it and lift it for them, that shoulder by definition is not frozen. That's just shoulder that doesn't have a very good rotator cuff or has problems with the motor. That distinction has to be made. The other thing is frozen shoulder is basically inflammatory process that's often associated with patients with diabetes or low thyroid. And we can see it just for unknown reason, the capsule of the shoulder gets inflamed. And that inflammatory process can last between 6 and 18 months. And what it does is it goes through 3 phases: inflammatory phase, frozen phase, and then thawing phase. And those shoulders are that's the classic example of frozen shoulder, but that's rare. More often, patients have an injury. They don't move their shoulder as a result of that injury. And then they lose motion because shoulder joint loves to be moved and wants to be moved. And if it's not moved, it ends up being stiff. So that shoulder is not technically frozen shoulder. That shoulder is just stiff shoulder from an underlying problem. So again, frozen shoulder, which is adhesive capsulitis, it's an inflammatory process. It's treated with therapy and anti-inflammatories and injections periodically. Stiff shoulder from another underlying pathology we need to address the underlying pathology and the stiffness in the shoulder simultaneously.
Got it. Well, we have more questions. So can you explain double crush syndrome?
Can you tell me what yes. If I'm understanding what their common term that they're describing, but basically having a nerve be compressed at 2 different spots. Either most common, for example, we'll see patients that have cervical spine problems or like a little slip disc, and the nerve is compressed in their neck, and then they also happen to have a carpal tunnel. So they'll have 2 places, and then they'll have this addressed, for example, but then they'll find out, oh, you also have this problem. So it's rare, but usually, you can you always have to keep an eye on it and look for it. So that's what they mean is that as the course of the nerve comes out from the spinal cord out to periphery, the nerve is having blockage in conduction at 2 different spots.
Can you share with us why someone would have a total fail of a knee replacement? What would be the contributing factors for that?
I don't know what they mean by total fail. Failure causes of total knee are 1%, 1 to 2% nationwide is the infection risk. There's failure as a result of malposition of the implants. There's a failure as a result of stiffness. Patients that have developed stiffness, those often will go hand in hand. There could be failure of bonding of the cement and an implant interface that causes micromotion, which causes persistent pain. So that we call that loosening. There's a failure of, you've had a total knee for 15 years and that little plastic insert is worn out, and as a result created microparticles that are now distributed in the joint, and then your immune system tries to eat them up and then causes loosening of the implant in the process of absorbing these little microparticles of polyethylene. So I'm not sure what they're referring to by total failure, but one of those categories.
I think they were just looking for explanations, and you certainly gave them lots of explanations of what might have happened. And then lastly, someone is asking if you could talk about the differences between a right shoulder slap and a slap repair versus a bicep tendonitis decompression.
Sure. So pathology with the long head of the biceps can occur anywhere along the course of the biceps tendon, so in that little groove, and then inside of the joint. And then at the attachment point, that biceps attaches, which I didn't point out, at the 12 o'clock position on our socket. So right at the 12 o'clock is where it anchors and attaches to the labrum there. That area is called slap. So patients that have, for example, my overhead athletes, volleyball players, swimmers, will injure the biceps tendon, and they tend to be young athletes, and they'll pull that whole anchor right off the 12 o'clock position. the rest of their tendon is fine and looks intact, and it's mobile and it moves in the groove fine. So those need to be repaired back down to that 12 o'clock position to stabilize that detachment. Other people, more in their 40s, 50s, will develop tendonitis, and again, that tendonitis is probably secondary to something else going on, usually rotator cuff tear or some kind of other pathology in their shoulder, and often will have almost fraying of that tendon, and sometimes that they'll even have a partial tear, and some people will even get a complete tear. And in those cases, we detach that biceps out of this attachment point at that 12 o'clock position, and we can either reattach it on the bone, on the humerus, or we can just let it go. European way is you just let it go, and they have plenty of data to suggest that patients do fine. Americans, we like to make things more interesting and complicated, so we almost always reattach it on the bone. And so we kind of have this shoulder society debate back and forth across the Atlantic, which one is better. But one is called tenotomy, where we just let it go. That's a lot of the European surgeons will do. And in America, we'll try to tenodese it, which is reattach it at various points along the humerus.
Someone is asking, since we're talking about anchor points, one of the questions asked is there more infections on a composite anchor versus a metal anchor?
No.
Nope.
Simple.
That's it.
No.
All right. Well, Doctor, I do appreciate it very much for taking our questions today and doing such a fabulous job. I can say that a lot of the messages are, I don't have a question. I just want to tell Doctor it was great information and we appreciate his time. So if you wouldn't mind, Doctor, in just a second, I'm going to have you flip the side. I'm reminding everybody that our sponsors today are providing door prizes for those of you that are in attendance today, and they've randomly selected it. We put it on a slide, so it'll be easy for you to see your name. They will contact you if you are the winner. So go ahead and change that. Oops, the last slide.
I will. I just skipped through.
And as a reminder, you will be receiving your certificate tomorrow at approximately 1 p.m. So look for that. It'll say that your certificate has arrived. So we can see all of the different winners here. Please take a second. And we want to thank you very much for participating in the Endless Summer 3-day event this year. We do appreciate your time and hope that the webinars that we provided to you have been beneficial to you and your team. When possible, please utilize one of the companies that help sponsor this, as they are invested in you and your success. We thank everybody for attending. Bye-bye now.
Thank you. Bye.